Good evening, ladies and gentlemen. Today we're going to comment on an article that was published in Radiology this year. The title is Myocardial Fibrosis and Inflammation in Liver Cirrhosis, an MRI study of the liver-heart axis. This is a study that was conducted in a couple of centers, both educational hospitals, one in Bonn, Germany, and another in Frankfurt am Main. It's a very interesting review, and we're going to fly over some of the main details. As a matter of introduction, just to mention, we know that chronic liver disease has a way of beginning as liver fibrosis under different stimuli. We have infectious hepatitis, we have alcoholism and other factors, also including obesity, that produce fibrosis and then eventually cirrhosis. This, of course, has a way of producing portal hypertension or liver failure, or both. What is being studied under this article is an entity called cirrhotic cardiomyopathy. So this is an entity that's seen in 50% roughly of advanced liver disease, and this entity is independent of underlying etiology. So this is not the same as alcoholic cardiomyopathy. I mean, you can see cirrhotic patients who have an alcoholic background. They will also develop cardiomyopathy because of their alcoholic ingestion. So, I mean, this is a different entity altogether, and its pathophysiology is poorly understood. It's not completely dominated yet. So this is just an image to kind of relate what's happening here. We have chronic liver disease, as in cirrhosis, that's basically punching the heart over there to the right. We have heart damage due to chronic liver disease. So a couple of things to keep in mind, that when we do T1 mapping on MRI images, this is giving us an image or an idea of myocardial fibrosis. We can see diffuse tissue pathologies through the T1 mapping, specifically like non-ischemic cardiomyopathies. So this would include fibrosis in this setting. T2 mapping is described as good for detecting edema. So this would be the case in inflammatory myocardial disease. Also, classically, in this emerging topic, the evaluation of myocardial strain is important. Basically, myocardial strain has to do with the deformation of the normal structure of the myocardial walls, and so the myocardial wall is deformed, and that's what we call myocardial strain. And this is also analyzed as a factor. So this is basically a comprehensive multiparametric hepatic and cardiac MRI study in patients with liver cirrhosis without any known cardiac disease. So the purpose is to investigate the extent of subclinical imaging changes, such as fibrosis and inflammation in these patients, and of course compared to a control group. So the relationship is to be studied between the severity of liver disease and the degree of myocardial involvement. So the summary is basically, as we've mentioned, studying inflammation and myocardial fibrosis and systolic dysfunction. Just to mention that they divided the groups in Child-Pugh class A, B, and C. So basically what that means is that we're having a clinical classification that stratifies the severity of cirrhosis, and then that also is analyzed, in relation to the MRI findings in the liver and in the cardiac MRI as well. So basically, we had a number of 96 patients that all had liver cirrhosis, and basically, to end up, they had 42 patients that were included, having excluded all who had advanced chronic kidney disease, a contraindication for MRI, any pre-existing cardiac disease, malignant disease, acute clinical deterioration, or refusal to participate in the study. So Here are some tables. Basically, I'll just emphasize those that have a p-value less than the 0.05, which is implying a statistically significant value. So some are clinical parameters. We won't focus much on that. The heart frequency was seen to be related statistically significantly with the cirrhosis in relation to healthy control participants, but then the cardiac index and left atrium volume index as well. Here, we'll basically focus on the important findings, and you can read up the article yourselves later. The late gadolinium enhancement was statistically significant. It's an important finding, and we'll see that later. Some other MRI findings, both in the cardiac MRI and the hepatic MRI. So here we have a clinical and MRI analysis of the cirrhosis subgroups according to the Child-Pugh classes. So we have, according to the severity of cirrhosis or end-stage liver disease, serum albumin and total bilirubin were statistically significant. You can see that albumin level drops as you go further into advanced stages of liver disease. Then the cardiac MRI parameters, basically late gadolinium enhancement was statistically significant. You can see that it's significantly higher in the advanced class C group, 13 versus 1.6. The late gadolinium enhancement, we'll mention that later. Also the T1 relaxation time, native, which means without any enhancement, no gadolinium yet applied. And the hepatic MRI parameters, this is very important. We'll talk about that a bit later. The MR elastography-based liver stiffness, and also the extracellular volume fraction, and the T1 relaxation time. So basically, this is the proposed model for how this happens, the pathogenic mechanism of the cirrhotic cardiomyopathy in patients who have advanced liver disease. So you basically start up having chronic liver injury that leads to hepatic fibrosis. The extracellular space is expanded, and you eventually end up having increased intrahepatic vascular resistance. So we all know this, but this leads up to portal hypertension. This, in its turn, leads to the circulation of vasodilators, and this causes, of course, vasodilatation on a systemic and also a splanchnic level. So this ends up leading us to decreased systemic vascular resistance, and the blood volume is redistributed. We have a central hypovolemia, which is leading us to a hyperdynamic syndrome. Basically, it's like you can imagine all the blood flow is centralized peripherically, and we have a hypovolemia centrally, which is then causing the whole cardiac cycle to be affected, and then you have factors that include potent vasoconstricting systems such as renin, angiotensin, aldosterone system, and also the sympathetic nervous system. So this leads to, as I mentioned, a hyperdynamic circulation, and this eventually ends up stressing the heart, causing cardiac dysfunction and fibrosis, and leading to this cirrhotic cardiomyopathy. There are other things also involved, but this is basically a bit of the summary that is mentioned there in the article. So this figure is figure 3. These are representative examples of some participants with liver cirrhosis with positive late gadolinium enhancement. So basically, we have the distribution of the positive late gadolinium enhancement, or LGE, to the segments of the myocardium that is predominantly affecting the infralateral aspects. And according to what I read and understood, is that this is typical for these type of lesions. So the contrast material enhanced segmented inversion recovery gradient echo sequences in short axis that are over here, these images, are showing focal LGE and then diffuse pattern LGE. we have another set of images that show clinical examples of first the healthy control participant, and then the other participant has Child-Pugh class B cirrhosis. So this is comparing control versus cirrhosis in a couple of patients just to exemplify the findings. This is multiparametric hepatic and cardiac MRI parameters. So the quantitative maps are given for hepatic and cardiac T1 relaxation times up here. You can see that there is a difference there in the mapping. Also in the ECV, which is the extracellular volume. Then if you go down to the T2 relaxation time, you can also see that it's, the map is significantly altered. Then also the MR elastography-based liver stiffness. This is also showing a significant change. Actually, one of the main values or accomplishments of this study is focused on that later. So basically, the quantitative parameters are considerably higher in the patients that have cirrhosis. Then here you have the heart images. This is the T1 map, the ECV, and the T2 map as well. So you can see that the heart is affected in the late stage cirrhotic diseases, or in this case, Child-Pugh B. This is correlating with the plotted values there. This is the distribution of quantitative myocardial MRI parameters in the control group, and compared with the subclassified cirrhosis group A, B, and C, as you see. So basically, this is showing that the higher the advancement of the liver disease, the higher T1 relaxation time. And this is what we mentioned before, has to do with fibrosis. And here, myocardial ECV, or extracellular volume, the same. It goes higher. This is a neat correlation, that respects the value of hemoglobin, and before and after the application of gadolinium, how the image and the signal intensity is affected. And this has also been shown to be correlated with the changes in this case, when you talk about myocardial damage. So the T2 relaxation as well, which we mentioned, talk about edema, and the LGE percentage with late gadolinium enhancement. This is also shown in fibrosis, among other conditions. Figure 6 are scatter plots. They are showing the correlation between the myocardial and the hepatic MRI parameters within the cirrhosis group. So here you don't have any healthy control participants, and this is basically showing the correlation between the hepatic values and the myocardial values. So like in several of these cross-references, you're seeing a positive relationship between the advancement of liver disease and the myocardial affection. Some of the important values to emphasize here, well, the Child-Pugh score was significant from a statistical point of view. Also the serum albumin, we mentioned that. Then we had the MR elastography-based liver stiffness, which was the only one that survived the filter of moving from univariable analysis to multivariable analysis. When this analysis was done, the only value to show itself statistically significant was the MR elastography-based liver stiffness. Also, some other that are very important to mention, because their p-value was less than 0.05 when it was univariable analysis, which was the hepatic native T1 relaxation time and the hepatic extracellular volume fraction. Then here's some other things that are important. This is correlating the hepatic and cardiac MRI parameters within the cirrhosis group. So this is excluding the control group. This here would be the hepatic values, and this would be the cardiac MRI parameters. So you see there are several correlations here. I hope you're getting the idea. We'll conclude later, and you kind of can knit this whole idea together. But all of these different values in the cardiac MRI, several of them are correlated to several of the hepatic MRI values. So in conclusion, this is a comprehensive MRI study which is showing the high burden of myocardial disease in patients with liver cirrhosis. So these patients are showing signs of systolic dysfunction, elevated parameters of myocardial edema and fibrosis. Remember T2 and T1 respectively, the mapping of both. Edema T2 and fibrosis mainly T1, but not only. You remember we had the extracellular volume and also the late gadolinium enhancement, which are very important in the evaluation of fibrosis, because basically the tissues, as I reason it, they receive the enhancement later because of fibrosis. So you will have a much later enhancement of that tissue because it's not well perfused. Then you have intensified values that shoot up as severity of the liver disease advance. So the more sick your liver is, the sicker the heart will be as well, so to speak. Myocardial fibrosis and subclinical myocardial inflammation, that is before symptoms start, seem to be a structural component of cirrhotic cardiomyopathy. So again, inflammation and fibrosis seem to be a part of cardiomyopathy in the context of cirrhosis, to put it in other words. The MR elastography-based liver stiffness in patients with cirrhosis was seen to be an independent predictor of late gadolinium enhancement, which is speaking of, again, fibrosis in this case. So non-ischemic LGE lesions, LGE referring to this, again, late gadolinium enhancement, because LGE is also seen in ischemic lesions. But when we speak of non-ischemic LGE, it's arrhythmogenic. So this is producing major adverse cardiac events and then a poorer outcome in patients. This is very important because this is bringing us to the need of closer cardiologic checkups in patients with clinically advanced liver disease. Basically, when you have clinically advanced liver disease, as in cirrhosis, or imaging-based fibrosis with markers high, then this closer checkup is proposed to be necessary. MRI in patients with cirrhosis, as studied in this article, is shown to be non-invasive and sensitive as means of tissue characterization to show a diffuse pattern of myocardial fibrosis and inflammation. There is a commentary article in the same volume that basically two authors here, Albert de Rose and Hildo Lamb, they're showing some of the common threads seen in these articles. I won't repeat those concepts, but very interesting read. They are showing a couple of limitations. Basically, one is the coronary artery disease was judged clinically and not through coronary angiography. So because it was not performed, it could be a potential confounder. They were not, in other words, really sure if they had coronary artery disease or not. It was just based on clinical information. Also, they mentioned some of the other limitations, that alcoholic effects can be a possible confounder. You had many of the patients that had alcoholic cirrhosis, and these could have effects on the myocardial tissue because of the alcohol itself. But they reasoned that no difference was seen between the two groups because there was cirrhosis in patients with alcohol-induced liver disease and those who did not have any alcohol as the etiology of the cirrhosis. So since there was no difference between both groups, non-alcoholic and alcohol cirrhosis, they reasoned that that may not have been a significant confounder. Some strengths of this study is it was a very well-designed prospective observational study that is showing a multiparametric MRI with great detail in characterizing hepatic and heart disease. So concluding, basically, they say that the results of this study lend credibility to the role of diffuse fibrosis and inflammation as part of the pathophysiology that may lead to cirrhotic cardiomyopathy in patients with various stages of liver disease. So this was very useful to me, and I hope it was to you as well. These are some of the external figure references. Thank you so much for paying attention. Just as a mean of summarizing myself, I think this is excellent. I think this is very good. This is top-notch studying and state-of-the-art MRI applied to the relationship of cardiac disease in advanced liver disease in an entity that is not entirely understood yet. What was also emphasized in the commentary is that, well, you know, the proposed pathophysiology behind this disease. I say this: the interaction between the liver and the heart disease itself, and the cardiomyopathy that comes from cirrhosis independently. The pathophysiology that they had proposed was very well shown to be true through the different sequences at the MRI imaging. So I thought that was very interesting, and yeah, thank you so much again.